Hello everyone, I'm Rachael Lowe from Physiopedia and today I'm talking to Kevin Bruce. Hi Kevin.
Hi there.
Kevin, thanks so much for joining us today. Now we are delighted to have you as a non-physio talking to us today. So we're going to learn all about podiatry and the work you do with physios when treating feet and ankles and maybe other conditions today. But before we start, maybe you could give us a little introduction to yourself, tell people a little bit about yourself and what you get up to.
Sure, yeah, no problem. Hi, everyone. So, yeah, as Rachel said, I'm Kevin Bruce. I'm a podiatrist, have been for the last 10 years. However, my background was in sport. I did used to play football till I was 19, and then that didn't quite work out. So my first thought was to get into physio, actually. So maybe I'm a frustrated physio, but ultimately, for one reason or another, I ended up getting into podiatry, which I do love, and began my career in the NHS. But for the last 5 years, I've been working in private practice and very much in a multidisciplinary setting, both in my clinic in London as well as in Cambridge 1 day a week as well, with physiotherapists and other practitioners alongside me.
Okay, so before we do anything else, just for some people that may not be fully aware of what you actually do, maybe
Mhm.
you could just briefly describe the role of a podiatrist, or the scope of practice of a podiatrist, let's say.
Scope of practice, from my perspective, I'm a musculoskeletal podiatrist. I'm not talking about the routine work that some podiatrists do. I'm a musculoskeletal podiatrist, so primarily that's gait analysis related to a presenting pathology. So a patient would attend to see myself, they've got a pain somewhere. My job, alongside others, is to ascertain maybe the mechanism behind that issue, both through thorough history, but also then the assessment, which is going to be partially non-weight bearing. So, getting some joint range of motions, finding out how mobile perhaps this or stiff this patient is or is not. Static analysis, seeing them standing, but primarily functionally. So I'm looking at a lot of functional tests, not too dissimilar to perhaps how some physiotherapy tests, in terms of single limb squatting, in terms of then referencing how stable or otherwise they may be, both proximally or distally, and the single limb balance, heel raise testing, etc., relevant to their pathology, and then gait analysis, which is videoed. I will analyze that in slow motion, and in certain scenarios, I also have pressure analysis and gait assessments software as well to look further into that, both running and walking. So it's trying to be as appropriate as possible for each individual patient, and I tailor that accordingly, dependent on that person's needs.
Perfect. And interventions-wise, what would you do?
Well, that's interesting. I'm sure people think podiatrists. They think first thing they think is orthoses, right?
Yeah.
They think, oh, no, you're going to give everyone an orthosis. It's not always the case. Please don't tar us all with that brush. I mean, yes, it's a key part of our armory. We do prescribe them, but they're not for everyone. If we think it's appropriate, I'm going to use them. If I don't think it's appropriate, then I can give other advice as well. Footwear, I am going to give some exercises to a point. Obviously, like I say, I work with a lot of physios, so I am referring onwards for that, but I might start that process rolling. Likewise, I would expect perhaps certain physios to start orthoses rolling. You can use an off-the-shelf or even strapping to help that process to see how a patient reacts. I do a lot of strapping to see how patients do react to what an orthosis might do for a patient. So gaining confidence. I mentioned I am in private practice, so ultimately a lot of these orthoses aren't funded. So I have to get confidence from my side, but also the patient side that this is going to help. So that's why I do that quite a lot. So exercise prescription, modification of load. So you're talking training errors and etc. We're talking through all of these things, which history is key. I spend a long time taking history because it's such an important factor. Ultimately, you might modify a patient's or think you're modifying a patient's mechanics, but if their load management is all wrong from their training or whatever their activity levels are, and they're not strong enough to deal with what they're doing for whatever purpose, then you're going to bang your head against a brick wall no matter what intervention you put in place. So I think all of these factors are key as well. So some crossover to how you guys work, I'm sure, but I think that's a good thing that we can cross over boundaries as long as we communicate well between each other and we keep lines of communication open.
So let's talk about that. So how do you work with your multidisciplinary team? First of all, yeah.
Yeah, so primarily first port of call is usually a letter form or email, and then get the patient in and communicate back. Likewise, if there is, it's as simple as that. If there's something I'm not sure on, I have the relationship where I can pick up the phone or knock on the door and say, what do you think about this and what are we doing here? Because at one clinic I work at, we're all in a different room around the place. So it's physios in different rooms. I'm in a room, we can have an open conversation about a patient. So I think it's really important to talk face to face, or at least on the phone, because the last thing from my point of view I want is a patient coming to see me saying, oh, such and such has said you've done this wrong, and which is a nightmare. And I'm sure no one else would like that. At least and I'm not saying that that's how the practitioner has said it to the patient, but that's how they've then interpreted it. And if those lines of communication are open in that you have that ability to talk face to face, or at least on the phone, you can iron out issues you might have professionally face to face, ultimately for the benefit of the patient, because that's what we're all here for, right? So we're trying to get that patient better and back to whatever they want to be doing, whether it's sport, whether it's just be walking day to day pain free.
And so you've talked about your relationship with the physiotherapist. So you obviously work with the physios quite a lot, and there's a good open communication. I think you're advocating between both professions. There is some crossover, and obviously each profession has its own scope of practice. So that's why the communication is so important for the benefit of the patient, so that everybody's on the same boat, let's say, or on the same treatment plan. Who else do you work with in your multidisciplinary team?
Several foot and ankle consultants. So, they usually would be the first port of call for a patient. Not always. I might refer to them for further diagnostic tests, but they would be a key referrer to myself. I then have osteopaths who I work closely with in certain areas, as well as sports doctors and rheumatologists. I have quite a high, as well as sporting back patients. I also have pediatric. So I have pediatric consultants also who refer to me. So a decent variety of referrers and professionals that I work with.
Okay, that sounds good. It sounds it's so nice to hear when people are working in multidisciplinary teams, and I think it makes it so easy for us as professionals when we can work so well in a multidisciplinary team. Yeah, really good for our work and for the patients as well. So
yeah. It was a real frustration for me in the NHS that I was so isolated, and I don't know if that was just my area, and it just didn't work out reaching out to others. I was so isolated working in the NHS. You're really, sometimes you're doing an intervention and you're not 100%. If that had been backed up through others, helped. But yeah, it was frustrating in the NHS working out on my own. The setups I have now are really what I enjoy, and it works well.
So if someone finds themselves isolated like that in a hospital setting, how would you advise them to reach out to the people that they need to work with?
Yeah, I mean, it's hard to reach out to consultants in that setting. I think, you reach out to a foot and ankle consultant, it's going to be hard. They're busy enough doing whatever they're doing. You're not going to be able to open lines particularly well there. Although they might refer to you, it's going to be a process. I think hopefully you could reach out more with your other allied health professionals, your physiotherapy team, and hopefully arrange, even if you could, a joint clinic, perhaps, even if it's once a month. At least then you're sharing ideas. If you've got a patient who you're struggling to get better, and then you might think at the end of your treatment plan, actually, you could go and see physio now, or likewise, physio think, well, actually, maybe we get podiatry involved. Sometimes that's too late. I think if we got each other involved sooner, then it's better for the patient. You're on it straight away. You're not building up this chronic pain state, if you like, in a lot of patients, which is so hard to reverse. So yeah, I would try and open up lines of joint clinics. Like I say, at least once a month if possible. That's easier said than done, I'm sure. I'm not in the NHS now. I haven't been for a while. But if possible, that would definitely be something I'd be looking to do if I was still there.
Yeah, and not just in the NHS, but in other hospital settings around the world as well, where, and I'm sure it's the same in other hospital settings where everyone's always very challenged in those settings. So, but joint clinics is a really nice idea. Let's think about those joint clinics, what So we could talk about what sort of conditions you see sort of regularly. What are the common conditions you see? What conditions would you typically end up in the joint clinic with your physio?
Well, I think, pretty much anything I see could ultimately be seen by physio as well. You talk something as perhaps you might think podiatry focused as a second MTP joint problem, then okay, you might think that's podiatry, offload this or whatever you think is causing it, optimize perhaps something to help them. But if they've got issues with calf muscle, whether strength or stiffness around there, then that could be a physio intervention you're looking at assisting with there as well. So something like that definitely would always be advocating people involved, physios involved with. But the typical conditions I'm seeing are as you would expect. Plantar heel pain, your plantar fasciitis group of conditions, particularly I see a lot of Achilles tendon pathology, tibialis posterior dysfunction or issues around that area. Certainly they're probably the big few that I see. I see a lot of runners, so I do get a lot of medial tibial stress syndrome as well. And they would be the ones I would say particularly I'm seeing a lot on my radar. All of those, I think there's no problem to have joint interventions there. It's easier said than done. A lot of patients, again, might not want to, if they're self-funded, not want to see too many clinicians. So I will mention that this is what I would suggest, but that's fine. We'll do what we can here. Well, this is what I would advocate. And again, I'll touch on, it's not just insoles. I'm advocating other exercises, strengthening, footwear interventions, etc. And that might be some cases where I don't get to refer to where I would prefer. But the patient is well informed of the route that I would normally take, and they're happy usually with that. I think, again, I touched... I didn't touch there, but also looking further up the body, patellofemoral pain again. I might see that late on, particularly if interventions have failed. And it's like, go and see the podiatrist. So there are identified risk factors that where a podiatrist might help, which might help direct when a podiatrist is needed. You want to get pain in single leg squats. You want with identified increased midfoot mobility or reduced stiffness of the midfoot. They are candidates perhaps to be benefited through orthoses. So there are tests you can do to say, should I refer to the podiatrist? Well, again, there are papers on that. I think it's Christian Barton's work particularly has summarized that, and reading into that, those tests are readily available to read up on. So
which tests are those then?
The single leg squat.
Yeah.
So if you've got a patient with patellofemoral pain, do a single leg squat and they get pain doing that. If you put a simple, perhaps off-the-shelf medial arch support in there and that alleviates symptoms, they have been shown to gain benefit from orthoses, foot orthoses, and those with increased midfoot mobility as well. So from what a classical placing the patient in a neutral position to then allowing that to relax. The spread of the midfoot, it was defined as their mobility levels, increasing mobility levels. And again, patients who displayed higher levels of midfoot mobility benefited from foot orthoses. So not like I've touched on, not everyone's going to benefit from orthoses. Absolutely not advocating this for everyone. But there are two simple tests with patellofemoral pain, for example, where orthoses, you can guide yourself a little bit if orthoses will help, and should I then refer to the podiatrist?
Yeah, so those are two really good examples. So this is what I was thinking. Those are two good examples of where we should be referring to the podiatrist. In what situations do you think physios should be referring to the podiatrist? You've mentioned those two. Are there any sort of other situations where we should be utilising your services more?
I like to see patients as early as possible in their journey. I don't want to see them at the end when they've hammered their head against a brick wall and they're not feeling great about therapists, perhaps. They're in pain still. So it's identifying those patients who should be referred to us early. I think in plantar fascial pain, again, those patients who have been shown to have a flatter foot type, again, this is systematic reviews, have been shown to be benefited with orthoses. So if you don't want to jump straight in there with it, the patient's reluctant, strap them up, put a good strapping on there to replicate a medial support and see if they get better with that over the 3-4 days, whatever. And if they do, it's a decent indicator that orthoses are going to help that patient. And then I would refer, like I say, to someone like myself. Likewise, you've got tibialis posterior problem. It's simple one that orthoses often help a lot. I like to see those patients, again, as early as possible in their journey, because the earlier you get that intervention in, usually the quicker you reverse that pain cycle, whether it's a dysfunction. Again, an earlier dysfunction is easier to treat with orthoses than a later dysfunction. But again, I think in that case, they're going to need orthoses. So get in there early with them. Yes, strengthening is a key part of that, particularly with the progression, but orthoses early as well to assist that, I think. So the sooner the better in those cases.
Okay. So I think that's useful advice, really. I think remembering, in particular, some of the conditions that you've just mentioned, and then remembering to refer early is probably a good thing. And I guess that's...
Pick up the phone and ring and say, look, I've got this patient. What do you think? Should I refer to you? Or email, should I refer to you if you've got that relationship with a podiatrist? There are a lot of podiatrists quite active on Twitter as well, who would probably be happy for you to say to them, look, I've got a patient who has it. Don't be given too much detail, but would you want to see a patient with this? And I think trying to find that out is helpful for the patient, right?
Yeah, absolutely. It's a good point. Is there anything else? So we've talked about referring early. We've talked about using good communication as far as joint clinics and things are good ways to collaborate. Is there anything else that you wish that physiotherapists would do with our joint patients or in our multidisciplinary collaboration?
I think perhaps maybe say. I think even this is the same in the podiatry world still, unfortunately, that we've been left with this understanding that we're trying to balance the foot to neutral, if you like, which has been shown more and more, even in the last week, to be a bit of a nonsense. That is, in the first case, you often can't even balance the foot to neutral with orthoses dynamically. And the testing, traditionally the root testing that we brought up on, if you like, a lot of those tests have no implications to kinematic analysis or movement analysis. It just doesn't replicate. So we don't want to be telling our patients that, they've got flat feet, so they need insoles. I guess that's not the types of tests we want to be doing. So don't send to the podiatrist because they said I've got flat feet, so I probably need insoles. That's not the reason why. It's more the patient-directed testing that I think is more relevant to that. There's some good papers, and I can send links to these, particularly coming out of Salford Uni. Chris Nestor's group, Hannah Jarvis released one last week, stating how we should really be getting rid of the root paradigm and just forgetting about it. It's not useful to podiatrists anymore, and that would have a knock-on effect, obviously, for other professionals. I like to think that most of us now are utilising more of a tissue stress approach. So what tissue is injured, reduce the stress of that tissue, on we go, if you like, as opposed to, balancing feet into neutral, which is a bit of a nonsense. And I would step away from terminology and trying to think that that's what podiatrists are trying to do. We're not. At least I think most of us aren't anymore.
Yeah, I think that's good advice. It is good. And I hope that you'll share those papers with us so that we can have a read of those as well. So we've talked about a lot of things here. Is there anything that I haven't possibly directed my questions at you appropriately? Is there anything else that we should talk about that I'm not aware of?
I think, we've covered quite a lot, haven't we? I think it's great to have relationships with other practitioners, particularly physio, because I think we do work so well together. I get on great with all the physiotherapists that I work with. So I think don't be... a podiatrist wants to speak to other people. We're really lonely people. We do work in isolation generally. So pick up the phone and speak to one of them. They'd be really happy to speak to you. And share. I think it's shared responsibility for patients eases the burden on us all. We're all wanting to try and get a patient better. Don't take it on yourself. Use others. And I think that is a key message to what we're trying to achieve together. And ultimately, we're on the same page with that. And don't see it as a threat. I think, like I say, we do sometimes cross over a little bit. And I'm not trying to be a physio, and I'm sure a lot of physios aren't trying to be podiatrists. And that's why I have no problem with a physio perhaps starting a patient off with a simple off-the-shelf device. And likewise, I hope physios don't have a problem with me perhaps starting off a simple strengthening program or whatever that may be. But I'm always going to then say, okay, physio are going to help take you further or direct things slightly differently with you. And I think that's absolutely fine. I'm happy with that, and it works well.
Yeah, no, it sounds lovely. It sounds great. What about the situation where a physio doesn't have access to a podiatrist?
Oh, good one. Well, then exactly, you do what I've touched on. I guess, your physios aren't I don't think, making custom orthoses, but you can. I spent a large part of my NHS career not using custom orthoses because we didn't have the budget for it. So you can modify off-the-shelf devices to a point, but you need to have good understanding of the foot. I think you can't just go in there and do that on a whim. Ultimately, we have to bear in mind we're trying to alter with orthoses the kinetics at foot level, so the force is applied to different tissues. If you reduce a force in one area, you're going to increase it in another area. So we have to have a knowledge of whether that area is going to be able to tolerate that load. So understanding basically a foot function is key if you're going to not have access to a podiatrist. And if you don't have access to a podiatrist, maybe try and shadow one once or twice and get a bit of an idea of what you can achieve to a point. And read up on, like I say, the papers that I'll put up will start you off, both from the if you like, discounting routine theory towards tissue stress theory, then this is how we should be thinking. And you can always do something, I think, to help a patient. If you think an orthosis is going to help, but do it with an understanding of how it could also have a detrimental effect.
Okay, good advice.
Yeah.
Yeah. Okay, good. Is there anything else that we haven't talked about that you think we should talk about?
I don't think so. I think I like a lot of the developments that are ongoing at the minute. Gait retraining is one that I utilise quite a lot. And again, that's a bit of a crossover area. I might look at patients running with physio as well, and we'll both interject. I'm not trying to make massive changes to someone, but a lot of elite athletes might not want to make massive changes in terms of their foot gear, in terms of orthosis inside. So can we make some tweaks, particularly medial tibial stress syndrome, typical varus limb. So can we widen that stance? Is that going to help? So again, working together, we can identify things like that. So that's an interesting area I like a lot. I think we've covered quite a bit together. Yeah, it's good.
Yeah, no, it's a good conversation. I think these conversations are really important to have to understand how multidisciplinary collaborations can work, and if they're not available, how they can work, things like that. So it's been absolutely awesome to talk to you today to try and have an understanding of that and on how we can be working together and how we can do things better, I think, as well. So before we sign off, where can people find out more about you and the work that you do and where you are?
Okay, so I have my own personal website is mskpodiatrist.co.uk. I work out of a clinic which is First Podiatry, and that is firstpodiatry again. .co.uk. And research-wise, hopefully I'll be coming out with some bits and pieces related to pediatric, hypermobile pediatric patients and some of their gait adaptations they utilise or functions that they utilise commonly. So hopefully in the next year or so we'll be seeing bits and pieces like that from myself. And yeah.
Excellent. We'll look out for that. And as you've already mentioned, that people can go to Twitter and ask you any questions they like.
Please do.
What's your Twitter handle?
My Twitter handle is @KB Podiatry.
Okay, cool. You may be inundated now.
That's fine. Please throw them at me. I'll do my best to react. I've got 2 very young children, so please bear with me.
Kevin, it's been an absolute pleasure to talk to you today. I think that's been really quite useful, actually. So thank you very much. And I hope that this conversation will encourage people to take forward their collaborations with the podiatry profession.
Brilliant. We'd love that.